All right, let's jump right into a scenario that trips up medical coders all the time. Picture this. A patient suffers a subsequent acute myocardial infarction after being discharged for an initial acute MI that occurred just 18 days earlier. It's a highly specific, very realistic timeline. But here's the million-dollar question for our revenue cycle. Which ICD-10-CM code actually goes first? Is it the original infarction or is it the new one? If you're pausing to think about it, you are in exactly the right place. By the end of our time together today, you won't just know the answer, you'll understand the exact clinical and coding logic driving it. Welcome, everyone. I'm so glad you're here. Today, we're diving deep into mastering myocardial infarction coding. We are going to bridge that tricky gap between the physical reality of a heart attack in the clinical setting and the strict, highly nuanced ICD-10-CM rule sets we have to use every single day. We're going to make these complex codes not just understandable, but honestly, genuinely fascinating. Here is our quick roadmap for this explainer. First, the anatomy of an infarction. Second, diagnosis and clinical workup. Third, the 5 types of MI. Fourth, subsequent MI coding guidelines. And finally, some real-world coding scenarios. Okay, Section 1, the anatomy of an infarction, the physical event. What's really crucial here is establishing our baseline. When we say myocardial infarction, what are we physically talking about? We're talking about irreversible myocardial cell death, or necrosis, caused by prolonged ischemia. Take a look at the specific area of infarct highlighted on the heart wall here. Blood flow literally stops. The tissue is starved of oxygen and it dies. That physical, biological reality is the anchor for absolutely every code we're about to discuss. And this perfectly illustrates how the ICD-10-CM manual organizes that physical progression. The entire ischemic heart disease block runs from I20 to I25. It starts at I20 with angina pectoris, moves right into I21 for acute myocardial infarction, and then I22 for subsequent myocardial infarction. From there, we see I23 capturing current complications following an MI, I24 for other acute ischemic heart disease, all the way to I25 for chronic ischemic heart disease. It's a beautifully logical progression of the disease process. Moving on to Section 2. Diagnosis and clinical workup, real-time identification. It all starts with the patient's symptoms. Usually, they present with sudden, crushing chest pain that often travels right up into the jaw or down the left arm. They might be dealing with shortness of breath, dizziness, nausea, or vomiting. Or maybe they have known heart disease, but the pain is suddenly way worse than usual. Recognizing these severe warning signs is the crucial first step that kicks off the clinical workup. Once those alarm bells ring, the workup happens fast. The flow usually involves a 12-lead ECG, an echocardiogram, and critically, a check of cardiac enzymes, specifically troponin I. We heavily rely on this biomarker to confirm an acute MI. Providers might also order a cardiac MRI or go straight to coronary angiography to get a direct look at the vessels. But keep that reliance on biomarkers in the back of your mind, because what happens when a patient passes away before we can even draw those labs? That brings us to our next section. Section 3, the 5 types of MI, clinical classifications. All right, there are 5 distinct types of MI. Type 1 is your standard spontaneous MI due to plaque rupture. Type 2 is secondary to an ischemic imbalance, like severe anemia causing demand ischemia. Now, I really want you to focus on type 3 for a second. This is a highly specific, totally critical scenario for us. We're talking about patients who suffer sudden cardiac death with symptoms suggestive of myocardial ischemia. They might present with presumed new ischemic ECG changes or even ventricular fibrillation. But here is the kicker. The death occurs before blood samples for cardiac biomarkers can be obtained, or before those biomarkers have time to elevate. Sometimes it's only detected retrospectively during an autopsy. Because type 3 cannot be classified strictly by biomarker elevation like types 1 or 2, it is assigned to code I21.A9 for other myocardial infarction type. It's a rare but incredibly important distinction for your CDI and coding accuracy. Rounding out the list, type 4 is related to percutaneous coronary interventions, and type 5 is related to a CABG procedure. Let's quickly zoom in on type 4. Here, we can clearly see the difference between a successful intervention and a severe complication. On one side, we have a successful balloon angioplasty and stent placement. But on the other side, we see what happens when things go wrong. Type 4A relates to the PCI procedure itself. Type 4B is an MI related to stent thrombosis, where a clot actually forms inside the stent. And type 4C is due to restenosis, a narrowing of 50% or greater after a previously successful PCI. Section 4. Subsequent MI coding guidelines. Rules of sequencing. So let's go right back to that 18-day scenario from our very first slide. The golden rule here is temporal. If a patient suffers a subsequent acute MI within 4 weeks of an initial one, the sequence of the I-22 and I-21 codes depends entirely on the admission circumstances. If they're admitted for an acute MI and have another one while they're still in the hospital, the I-21 code for the admission reason goes first, with I-22 as secondary. However, if they are discharged and then suffer a subsequent MI 18 days later, which is inside that 4-week window, the I-22 code must be sequenced first, followed by the I-21 code. And the biggest takeaway here? An I-22 code literally never flies solo. An I-21 code must always accompany an I-22 code. Why? To explicitly identify the site of the initial acute MI and to clinically indicate that the patient is still within that critical 4-week healing timeframe. They are a package deal that paints the whole clinical picture. Section 5, let's test your knowledge with some real-world coding scenarios. Here is our first scenario. A patient is admitted with an acute STEMI involving the left main coronary artery. No history of previous infarction. But a week later, during that exact same hospital stay, he experiences an acute anterolateral STEMI. How do we code this admission? Think back to that sequencing rule we just talked about. Let's break down the logic. Because the subsequent MI happened while the patient was still in the hospital for the initial event, the reason for the admission stays as the principal diagnosis. So the principal diagnosis is I21.01 for the STEMI of the left main coronary artery. The secondary diagnosis becomes I22.0 for the subsequent STEMI of the anterior wall. Makes sense, right? Let's look at one final, slightly tricky scenario. What code should be assigned when a patient is readmitted to the hospital with a new Type 2 acute MI occurring within 4 weeks of a previous Type 1 or Type 2 MI? We know they're within that 4-week window, so your gut instinct might be to reach right for that I-22 subsequent code. But wait, the official guidelines throw us a complete curveball here. The correct answer is to assign code I21.A9, myocardial infarction type 2. The ICD-10-CM official guidelines strictly state, do not assign code I22 for subsequent myocardial infarctions other than type 1 or unspecified. For subsequent type 2 AMI, assign only code I21.A1. There's actually an excludes one note under category I22 that explicitly enforces this. It just brilliantly illustrates that in medical coding, exceptions always exist, and knowing exactly where to find them is what makes you a true expert. Will this one exception change how you sequence your charts tomorrow? It definitely should. Decode healthcare with Harshal.